How to Save America's Healthcare. Economic Analysis. An Independent Academic Study. By TrueCapitalism, pseudonym, 2024 edition. Preface. This work is a rigorous economic analysis of the structural failures of the American healthcare system and a blueprint for its fundamental reform. It draws on the full tradition of market economics, from classical liberal political economy to the Austrian School of Economics, Ludwig von Mises' Critique of Interventionism, Friedrich Hayek's theory of dispersed knowledge and the price system, Murray Rothbard's analysis of the state as a monopolist of coercion, and modern public choice theory, to demonstrate that the healthcare crisis in the United States is, at its core, a manufactured crisis of government intervention, not a failure of voluntary markets. The analysis proceeds from first principles. Voluntary exchange, private property rights, and emergent price signals are the indispensable foundations of any system capable of delivering goods and services efficiently, innovatively, and equitably. These are not ideological preferences. They are economic laws, as immutable in their domain as the laws of thermodynamics in physics. Every violation of these principles generates predictable, observable consequences: malinvestment, resource misallocation, suppressed entrepreneurship, and eroded individual responsibility, all of which are on full display in American healthcare today. This book does not propose modest tweaks at the margins. The dysfunction is too deep, too structural, and too entrenched for incrementalism. What is required is the systematic restoration of genuine market processes, the unhampered price system, freedom of contract, open entry and competition, and the elimination of coercive third-party payment and regulatory cartels. Government cannot manage healthcare. It can only distort the knowledge-generating and coordinating mechanisms that only spontaneous market order can produce. The pages that follow are organized in 6 parts. Part 1 diagnoses the problem, tracing the crisis to specific interventions that sever the nexus between consumer, cost, and producer. Part 2 develops the Austrian and libertarian economic framework. Part 3 critiques recent expansions such as the Affordable Care Act. Part 4 presents a practical market reform agenda grounded in restored price signals and property rights. Part 5 advances the logically consistent radical horizon, the near-complete elimination of state intervention, and shows why Austrian economics demands it. Part 6 synthesizes the diagnosis, logic, and path forward. Part 1. The Anatomy of Failure: How Government Created the Crisis. Chapter 1. The Foundational Error: Third-Party Payment. The central structural fact of American healthcare is that, in the overwhelming majority of transactions, the person receiving the service does not pay for it. A third party, employer-sponsored insurance, government program, or insurer, pays the bill. This severs the direct economic nexus between consumer valuation and resource cost, destroying the informational and incentive functions of prices at the most fundamental level. From Austrian first principles, prices are not arbitrary numbers. They are knowledge surrogates that condense millions of subjective valuations and scarcities into actionable signals. Hayek, 1945. When the consumer is insulated from marginal cost, the price signal is falsified. Demand appears artificially high, providers face no competitive pressure to economize, and resources are allocated to lower value uses. This is not healthcare specific. It is the universal logic of interventionism that Mises identified: remove the consumer's responsibility for cost, and malinvestment inevitably follows. The catalactic process, the market's spontaneous coordination of plans through voluntary exchange, is replaced by administrative noise. The predictable results are chronic overconsumption, exploding expenditures roughly twice the per capita level of peer nations with measurably worse outcomes on numerous indicators, and suppressed innovation in cost-reducing processes. The crisis is not a market failure. It is the direct, observable consequence of the state's destruction of the catalactic process. To call this a market failure is to confuse the wound for the weapon. Economic principle. When the consumer of a good or service does not bear its cost, consumption rises beyond the efficient level, prices rise without competitive discipline, and the normal market mechanisms for quality improvement and cost reduction cease to function. This is not a feature of healthcare specifically. It is a universal property of markets, as well established in economic theory as any principle in the discipline. Mises demonstrated this with the precision of formal logic. The American healthcare system provides the empirical confirmation. Chapter 2. The tax code as the root cause. The third-party payment system did not arise spontaneously. It was created and entrenched by the federal tax exclusion for employer-sponsored health insurance, instituted during World War II and never repealed. This policy is a classic example of Misesian interventionism, a seemingly minor distortion that cascades into systemic failure because it corrupts the relative prices on which all rational economic calculation depends. Economically, the exclusion functions as an open-ended subsidy worth hundreds of billions annually, artificially favoring employer group coverage over individual purchase. It converts insurance from true risk pooling into prepaid consumption, encourages ever richer benefit packages since the marginal dollar of employer-provided benefit is tax-free, and ties coverage to employment, destroying portability and creating the phenomenon economists call job lock. The subsidy is also regressive in its distributional impact. Higher bracket taxpayers receive larger absolute benefits for identical coverage, a systematic violation of horizontal equity that persists entirely because of political entrenchment. From a public choice vantage, concentrated interests, large employers, insurers, unions, defend the status quo while diffuse costs fall on the uninsured, self-employed, and general taxpayers who lack equivalent organizing power. Austrian analysis reveals a deeper distortion. The tax code falsifies the relative prices between insurance and other goods, leading to systematic overinvestment in medical care at the expense of savings, capital formation, and other consumer preferences. The result is a capital structure misaligned with genuine consumer time preferences, the textbook Austrian definition of malinvestment. The reform implication follows directly. The exclusion must be replaced, not capped or modified. Any policy that preserves open-ended preferential treatment for employer coverage perpetuates the distortion, even in diminished form. Only a clean substitution, a fixed, universal, refundable credit available for any qualifying coverage, eliminates the relative price distortion at its source. Chapter 3. Price opacity and the destruction of markets. A market without visible prices is not a market, it is a command and control simulation dressed in the language of exchange. American healthcare has achieved near total price opacity through the chargemaster fiction, gag clauses embedded in insurer contracts, and administratively set government reimbursement rates that bear no relationship to scarcity or value. Consumers cannot compare, providers cannot compete on cost, and the entrepreneurial discovery process that Kerzner identified as the engine of market progress is crippled at the root. Hayek's insight is decisive here. The price system is not merely an allocation tool but a discovery procedure that utilizes knowledge no central authority can possess. When prices are hidden or suppressed, genuine economic calculation becomes impossible, not merely difficult, but epistemologically foreclosed. The contrast across healthcare sectors is stark and instructive. Cosmetic surgery, LASIK vision correction, direct primary care, and medical tourism, all operating outside the third-party payment system, exhibit falling real prices, improving quality, and expanding access, exactly as market theory predicts. The insured sector exhibits the opposite because government policy has systematically destroyed the prerequisite conditions for spontaneous order. The policy implication is unambiguous. Mandatory pre-service, all-in-price publication in standardized, machine-readable format, combined with the prohibition of contractual gag clauses, is not merely a reform but a restoration of the basic conditions that make markets possible. Without it, every other reform operates in an informational vacuum. The Surgery Center of Oklahoma demonstrates what becomes possible when prices are published. Patients travel hundreds of miles to capture savings of 60 to 80% on identical procedures, and local competitors are forced to respond. This is the entrepreneurial discovery process in action. Chapter 4. Medicaid, Medicare, and the Perverse Economics of Government Insurance. Medicare and Medicaid represent the purest form of third-party payment, fee-for-service reimbursement divorced from consumer valuation, administratively set prices that ignore scarcity signals, and benefit structures that systematically create dependency. These are not implementation failures. They are the logical consequences of attempting to replace the price system with political allocation. Medicaid's income cliffs generate effective marginal tax rates exceeding 50% in many ranges, actively discouraging work, savings, and human capital investment, the precise opposite of the incentive structure that a free and prosperous society requires. This is the Misesian interventionist spiral in its clearest form. The program designed to help the poor creates the incentive structure that perpetuates poverty. The solution, more generous benefits, deepens the trap. Medicare's administrative pricing propagates distortions throughout the entire system because its scale makes it a de facto price leader for the broader market. Austrian economics explains why such programs must fail at the level of principle, not merely in practice. They replace the market's trial and error discovery process with bureaucratic fiat, guaranteeing chronic misallocation and shortages. The fact that a growing fraction of physicians refuse Medicaid patients is not an implementation flaw, it is the market refusing to clear it below cost. Administered prices. Quantity rationing through waiting times and access barriers is the inevitable consequence of price controls, as every student of basic economics understands. The fiscal dimension compounds the structural problem. Medicare's unfunded liabilities, the gap between promised benefits and projected revenues, represent one of the most severe long-term fiscal threats in the country's history, dwarfing the official national debt. No amount of administrative efficiency or cost control experimentation can resolve a liability that is structural in origin. Only a fundamental reform of the program's incentive architecture can address it. Part 2. The Economic Framework, Why Markets Outperform Bureaucracies. Chapter 5. The Knowledge Problem and Healthcare Allocation. Hayek's knowledge problem is especially acute in healthcare, and its implications for policy are more radical than most analysts acknowledge. Every medical decision involves tacit, time and place-specific knowledge possessed only by the patient and treating physician. The patient's risk tolerance, subjective valuation of different health states, life circumstances, prior medical history, and the specific presentation of their condition at this moment. No central authority can possess, aggregate, or act on this knowledge without catastrophic loss. Attempts to do so through mandates, formularies, coverage rules, or clinical protocols necessarily produce systematic error, not error in the sense of suboptimal decisions by well-meaning administrators, but error that is structural and irreducible. The price system, by contrast, aggregates and transmits dispersed knowledge without centralization. It does not require that any authority know what patients value or how physicians should treat them. It creates the conditions under which patients and physicians can act on their own knowledge and signal that knowledge to the market through their choices. Markets therefore do not merely allocate better than bureaucracies in a quantitative sense. They are the only mechanism epistemologically capable of rational allocation in a complex social order. This is Hayek's deepest insight and the one most consistently ignored in healthcare policy discussions. Empirical confirmation abounds in every transparent healthcare subsector. Real prices fall, quality rises, access expands, and innovation accelerates. Bureaucratically governed sectors exhibit the reverse pattern because they suppress the entrepreneurial discovery process that Austrian economics identifies as the primary engine of economic progress. The asymmetry is not coincidental, it is causal, and no amount of administrative cleverness can overcome the epistemological barrier that Hayek identified. The empirical record confirms what theory predicts. Every sector of healthcare in which consumer price sensitivity has been preserved, cosmetic procedures, LASIK surgery, direct primary care, medical tourism, pharmaceutical markets with generic competition, demonstrates the standard pattern of competitive markets: falling real prices, improving quality, expanding access, and continuous innovation. Every sector governed by administrative pricing and third-party payment exhibits the opposite pattern. The contrast is not coincidental, it is causal, and the Austrian framework explains precisely why. Chapter 6. The Insurance Confusion and the Economics of Risk. Insurance is properly a device for pooling independent, uncertain risks among similar risk individuals. Its economic rationale rests on risk aversion. Individuals who are risk-averse prefer the certainty of a known premium to the uncertainty of a potentially catastrophic loss. This rational preference creates value through voluntary exchange when the risks being pooled are genuinely uncertain from the individual's perspective, genuinely independent across the pool, and genuinely similar across the members being pooled. Covering routine, predictable, or controllable expenses is not insurance. It is prepaid consumption financed through an expensive intermediary that adds administrative cost without adding risk pooling value. Comprehensive third-party coverage creates moral hazard on a massive scale, inflating demand for low-value services and eroding the personal responsibility that is both economically necessary and morally central to a free society. The Austrian critique is particularly sharp here. Comprehensive coverage does not merely increase demand, it destroys the subjective valuation process through which individuals determine what healthcare is worth to them, replacing it with the political process through which bureaucrats determine what benefits must be covered. Community rating and guaranteed issue. The regulatory requirements that prohibit risk-based pricing and mandate acceptance of all applicants destroy actuarial soundness by forcing low-risk individuals to subsidize high-risk ones. The adverse selection death spiral that Mises-Zion analysis predicts follows mechanically. As low-risk individuals exit a market in which they are overcharged, the pool becomes increasingly high-risk, premiums rise further, more low-risk individuals exit, and the market eventually collapses unless sustained by ever-increasing compulsion. This is not a theoretical possibility, it is the observed trajectory of every insurance market subjected to these regulations. Austrian theory adds a further insight of foundational importance. Genuine risk calculation requires free market prices and actuarially sound premium setting. Regulatory price controls render insurance mathematically impossible over time, not merely economically inefficient. When the relationship between premium and risk is severed by law, the informational basis for insurance contracts is destroyed. What remains is not insurance but income redistribution operating under the language of insurance, a substitution that creates the illusion of coverage while undermining its actuarial foundations. Chapter 7. Public Choice and the Political Economy of Healthcare Regulation. Public Choice Economics. The application of economic reasoning to political behavior reveals why regulatory capture in healthcare is not an accident but a structural inevitability. Producers in the healthcare sector, physicians, hospitals, pharmaceutical companies, insurers, are concentrated, highly organized, and face large per capita stakes in regulatory outcomes. They have powerful incentives to invest in lobbying, campaign contributions, and political advocacy. Consumers, by contrast, face diffuse costs and the classic collective action problem. Each individual consumer has a limited stake in any particular regulatory outcome and faces high costs of political organization relative to the small benefit of influencing policy. The result is a predictable and systematic imbalance. Organized producer interests prevail over diffuse consumer interests, and regulations are designed to protect incumbents rather than to serve patients. Certificate of Need laws protect hospital monopolies. Scope of practice restrictions protect physician incomes from non-physician competition. Pharmaceutical regulations impose barriers that slow generic entry and protect brand manufacturers. Licensing requirements restrict the supply of practitioners below the competitive level. In each case, the regulatory apparatus presents itself as a protection for consumers while functioning primarily as a protection for producers. Libertarian analysis adds a deeper layer. The state's monopoly on coercion makes rent-seeking not an aberration but the predictable outcome of political means replacing economic means. Oppenheimer. When the state possesses the legal authority to compel compliance with its rules, the incentive to capture that authority and turn it to private advantage is irresistible. The solution is not better regulation or more independent regulators. Public choice analysis shows these proposals are naive about political incentives. The solution is to remove the state's authority to grant the protections that make capture valuable. Eliminate the certificate of need requirement, and there is nothing to capture. Eliminate mandatory licensing, and the licensing board has no power worth lobbying for. Part 3. The Affordable Care Act, Compounding the Errors. Chapter 8. Diagnosing the ACA's Structural Failures. The Patient Protection and Affordable Care Act of 2010 is best understood not as a reform of the dysfunctional American healthcare system, but as the most comprehensive extension of the interventionist logic that produced the dysfunction. Its central premise, that prior government failures require still more government, is the classic interventionist fallacy that Mises exposed with analytical precision. Each intervention creates distortions whose solution is further intervention, spiraling toward total control unless the logic is interrupted by a return to market principles. The ACA's community rating and guaranteed issue requirements accelerate the adverse selection death spiral that the preceding analysis predicts. Its income-based subsidy structure creates new poverty traps with effective marginal tax rates that can exceed those faced by upper-income households, a structure that punishes precisely the behavior, earning more income, that would allow affected families to achieve genuine economic independence. Its mandated benefit packages eliminate the diversity of coverage options that a heterogeneous population of consumers with diverse preferences and circumstances actually needs. Its cost control experiments, accountable care organizations, bundled payment programs, comparative effectiveness research, the Independent Payment Advisory Board, since repealed, are bureaucratic substitutes for competitive market pressure that cannot achieve what only the price system can accomplish. Administrative cost containment does not eliminate the knowledge problem, it merely ensures that the wrong decisions are made more efficiently. After more than a decade of implementation, the ACA has not bent the cost curve, it has extended the broken model to more people at greater expense. The ACA universalizes and entrenches the third-party payment model rather than addressing it. It does not restore price signals, it multiplies the intermediaries who obscure them. It does not create competitive insurance markets, it further regulates them toward uniformity. It does not empower patients as economic agents, it converts them into passive recipients of politically determined benefit packages. In every dimension that economic analysis identifies as relevant to healthcare performance, the ACA moves in the wrong direction. The ACA is best understood as the Misesian interventionist spiral-made law, a structure in which each provision creates the problem that the next provision purports to solve, with the cumulative effect of expanding state control over an ever larger share of the economy. The exit from this spiral requires not better ACA implementation but a fundamentally different conception of the state's proper role in healthcare. Part 4. The Market Reform Agenda, Restoring Economic Logic. Chapter 9. Reforming the Tax Treatment of Health Insurance. The single most important structural reform is the replacement of the open-ended, regressive tax exclusion for employer-sponsored health insurance with a universal, fixed, refundable tax credit for any qualifying coverage. This reform directly addresses the root cause of the third-party payment distortion by eliminating the tax code incentive that privileges employer coverage over individual choice and comprehensive insurance over cost-conscious coverage decisions. The credit must be fixed in amount, not percentage-based or open-ended, to prevent the replication of the current distortion in a new form. When the marginal dollar of insurance costs exactly $1 regardless of tax bracket or benefit richness, the incentive to maximize insurance richness disappears, and consumers are restored as genuine economic agents with an interest in seeking value rather than maximizing untaxed compensation. Refundability ensures that the reform delivers its benefits to lower-income individuals who receive least from the current exclusion. Portability, achieved by decoupling the credit from employment, eliminates job lock, enables entrepreneurship, and restores the individual as the appropriate unit of coverage rather than the employer. These are not merely administrative improvements, they are restorations of the property rights structure that market order requires. An individual who owns their coverage can take it to any job or no job, and spends their own marginal dollar on it as an economic agent. An individual whose coverage is determined by their employer, subsidized by the tax code, and purchased by a third party is not. Chapter 10. Health Savings Accounts and the Economics of Self-Insurance. Complementing the reform of insurance tax treatment is the expansion of health savings accounts into true lifetime medical savings vehicles, uncapped contributions, full portability, use for premiums and long-term care costs, accumulation without forced spend down, and inheritance of unused balances. The economic logic is foundational. Individuals spending their own marginal dollars on healthcare make qualitatively different decisions than individuals spending a third party's money. The Rand Health Insurance Experiment, the largest randomized controlled trial in health economics, demonstrated that cost-sharing reduces total healthcare consumption by approximately 30% with no detectable deterioration in average health outcomes. This is not a small effect at the margin, it is a one-third reduction in expenditure with equivalent health results, driven entirely by the restoration of consumer price sensitivity. Scaled to the full American healthcare system, this implies hundreds of billions of dollars in annual savings without any reduction in population health. From an Austrian perspective, expanded HSAs also serve a capital formation function of considerable importance. Individuals who accumulate health savings over their working years are building a form of real capital that provides genuine security against future health costs, reduces dependence on government transfer programs in old age, and strengthens the financial resilience of households. A system that encourages such accumulation respects the individual's time preference and property rights. A system that discourages it, through tax structures that penalize individuals saving relative to employer-managed spending, distorts the intertemporal allocation of resources in ways that impoverish individuals and the broader economy. Chapter 11. Price Transparency as Market Infrastructure. Price transparency is not a policy preference but a precondition, the sine qua non of economic coordination. Without the ability to observe and compare prices before the point of consumption, consumers cannot exercise sovereignty, providers cannot compete for cost-conscious customers, and the entrepreneurial discovery process through which markets generate efficiency and innovation cannot function. Mandatory pre-service, all-in-price publication in standardized, machine-readable format is therefore not an intervention in the healthcare market. It is the restoration of the informational infrastructure without which a market cannot exist. The prohibition of contractual gag clauses, provisions that prevent insurers from disclosing negotiated rates to the patients they serve, follows from the same principle. These clauses are not legitimate commercial confidentiality provisions. They are instruments of market suppression that prevent the price signals on which rational allocation depends from reaching the consumers whose decisions they are supposed to guide. Their elimination is a removal of a government-sanctioned barrier to market function, not a new regulatory imposition. The competitive dynamic that price transparency unleashes extends beyond simple price competition. When providers compete for price-sensitive patients, they compete simultaneously on service quality, patient experience, convenience, and transparency of outcome data. The restoration of price visibility is thus a restoration of the full competitive order, not merely a cost control measure. Real-world evidence from markets where healthcare prices are published confirms this. Convergence toward lower prices, improved service, and expanded access follow transparency as reliably as the theoretical model predicts. Chapter 12. Health Status Insurance and the Problem of Chronic Illness. The most intellectually demanding challenge for market-based healthcare reform is the treatment of individuals who develop chronic or expensive medical conditions after purchasing insurance. The actuarially sound response, risk-based pricing that reflects each individual's actual health status, is both economically necessary for insurance markets to function and politically vulnerable to the objection that it makes coverage unaffordable for the sick. The economically coherent solution is health status insurance, a second-order insurance instrument that insures against changes in an individual's health status itself. An individual who purchases standard health insurance simultaneously purchases a health status insurance policy. If that individual subsequently develops a condition that places them in a higher risk category, the health status insurance pays a portable premium supplement covering the incremental cost of their changed risk profile. This supplement travels with the individual when they change insurers, eliminating the insurer's incentive to underserve the chronically ill. The economic elegance of this solution lies in its incentive compatibility. It preserves actuarially sound risk-based pricing in the standard insurance market, eliminating adverse selection dynamics. It eliminates the structural incentive for insurers to avoid the chronically ill. It provides genuine, portable financial protection to individuals whose health status changes. And it accomplishes all of this through voluntary exchange and market mechanisms rather than price controls that destroy market function while imperfectly achieving their stated goals. Chapter 13. Deregulating Providers and Expanding Supply. A reform agenda focused exclusively on demand-side interventions would be incomplete without a parallel agenda for supply-side deregulation. Certificate of Need laws, scope of practice restrictions, and mandatory professional licensing all function as entry barriers that protect incumbent providers from competition at the expense of patients. They are cartelization by regulation, the use of state coercive power to enforce supply restrictions that the market would not sustain voluntarily. Certificate of Need laws, which require government approval before healthcare facilities can expand capacity or new ones can enter a market, have been subjected to extensive empirical analysis with remarkably consistent findings. They raise costs, reduce quality, and limit access. The economic mechanism is straightforward and Austrian in character. Con laws are entry barriers that prevent the entrepreneurial response to profit opportunities from expanding supply, keeping prices above competitive levels and quality below what competition would produce. Scope of practice restrictions that limit what nurse practitioners, physician assistants, pharmacists, and other non-physician providers may legally do protect physician incomes at the direct expense of patient access, especially in rural and low-income areas where physician supply is chronically insufficient. The empirical literature consistently finds that appropriately trained non-physician providers deliver care of comparable quality for a wide range of common conditions at substantially lower cost. The restriction of their practice is a pure transfer from patients to physicians, achieved through the political mechanism rather than the economic one. The replacement of mandatory government licensing with voluntary accreditation, combined with robust tort liability for harm, preserves the genuine consumer protection function of quality signaling while removing the supply restricting cartelization function that mandatory licensing serves. Competing accreditation organizations have strong market incentives to establish and maintain rigorous standards, because the value of their certification to providers depends on its credibility with consumers. This is the market mechanism working as it should. Quality assurance through reputation and liability rather than through the political capture of a mandatory licensing apparatus. Part 5. The Libertarian Horizon, the Economic Case for Radical Deregulation. The reforms outlined in Part 4 represent a substantial and achievable agenda for restoring market mechanisms in American healthcare. They are defensible within the existing political and institutional framework and would produce significant benefits even if implemented only partially. However, a complete and intellectually honest economic analysis must go further. If government intervention created the crisis, does the logic of market economics, Austrian economics in particular, point toward its complete elimination? The answer, argued here, is yes, and the economic grounds for that conclusion are stronger than the political debate acknowledges. Chapter 14. The Case for Eliminating Medical Licensing. Requirements. Mandatory medical licensing is so deeply embedded in the healthcare regulatory landscape, and so widely regarded as a fundamental protection for patients, that questioning it appears almost irresponsible. Yet the economic analysis of licensing, not as it is hoped to function, but as it actually functions in practice, is clear, and its implications are more radical than most policy discussions acknowledge. The case for mandatory licensing rests on the information asymmetry argument. Healthcare consumers cannot evaluate provider quality and therefore require government certification as a proxy. This argument has surface plausibility but fails on examination. Information asymmetries exist in many markets: automobile repair, financial advice, legal services, restaurant food safety, where we rely primarily on reputation, competitive market discipline, liability law, and voluntary certification rather than mandatory government licensing. The existence of an information gap does not automatically justify state intervention. It justifies better information systems, which market entrepreneurship produces spontaneously when not crowded out by mandatory alternatives. The economic consequences of mandatory licensing are substantial and negative for consumers. Supply restriction raises prices above competitive levels. Standardized training requirements suppress experimentation and innovation in medical education. Interstate licensing barriers reduce geographic mobility of medical talent and create artificial shortages in underserved areas. The prohibition of unlicensed practice eliminates entire categories of lower-cost care that could serve patients who neither require nor can afford fully licensed providers. Each of these effects represents a real cost borne by patients, primarily lower-income patients with the fewest alternatives. Patients are sovereign agents capable of informed choice when provided with relevant information. The Hayekian insight applies directly. The knowledge of which provider is appropriate for a given patient's needs is dispersed and personal, not possessed by a licensing board. A richer, more granular set of quality signals, voluntary certification by competing accreditation bodies, reputation built through digital information platforms, outcome data published by providers, and liability consequences for poor outcomes, would give patients more relevant information than mandatory government certification, while expanding the supply of legal providers and driving down prices through competition. The full repeal of mandatory licensing requirements would unleash a supply-side response of considerable magnitude. The number of legally authorized providers would expand dramatically. Prices would fall in response to competition, and a greater variety of healthcare services at different price points would become available. The chronic shortages of primary care providers in rural and low-income areas, a direct consequence of licensing enforced supply restrictions, would ease as entrepreneurial entry responded to profit opportunities that current law forecloses. Chapter 15. Pharmaceutical and Medical Device Deregulation. The regulatory apparatus governing pharmaceutical products and medical devices, centered on the Food and Drug Administration, imposes costs on American healthcare and American innovation that are enormous, systematic, and almost entirely invisible in public policy debate. Its defense rests on the claim that consumers cannot evaluate drug and device safety and efficacy and therefore require government certification before access. This claim is not false, but it does not follow that mandatory FDA approval is the appropriate or most efficient mechanism for providing the quality assurance that patients need. The economic analysis must confront two types of regulatory error symmetrically. Type 1 error, approving products that cause harm, is visible, generates adverse political consequences for regulators, and produces news coverage. Type 2 error, failing to approve or delaying the approval of beneficial products, is invisible. Patients who die from diseases for which effective treatments exist but are not yet approved do not form advocacy organizations, do not generate political pressure, and do not impose reputational costs on the regulators responsible. The incentive structure of the regulatory apparatus is therefore systematically biased toward excessive caution, generating Type 1 error avoidance at the expense of enormous Type 2 error costs that are never counted in public assessments of regulatory performance. Austrian analysis shows that only market-tested entrepreneurship can optimize the risk-benefit frontier in pharmaceutical development. The knowledge of which drug or device offers the best trade-off of efficacy and risk for a given patient population is dispersed, context-specific, and emerges from the competitive market process rather than from administrative review. The replacement of mandatory FDA approval with voluntary certification schemes, in which manufacturers who believe certification adds value to their products can obtain it, and in which tort liability creates powerful incentives for safety, would accelerate innovation, reduce costs, and produce a richer information environment for patients and physicians alike. Drug development timelines measured in decades and costs estimated in the billions are not inherent features of pharmaceutical science. They are the products of a regulatory requirement calibrated to eliminate risk rather than to optimize the trade-off between risk and therapeutic benefit. The lives lost to delayed access are a cost of the current regulatory regime, not a neutral baseline from which reform would represent a departure. A system that respected the epistemic limits of central review would produce more treatments faster and at lower cost, with equivalent or better safety achieved through market mechanisms rather than administrative gatekeeping. Chapter 16. The Economic Logic of Full Insurance Deregulation. The economic case for full insurance deregulation follows directly from the analysis of insurance as an economic institution in Chapter 6. Community rating, guaranteed issue, and mandated benefit requirements all represent constraints on freedom of contract that destroy actuarial soundness, generate adverse selection, and ultimately make coverage more expensive and less available for everyone they purport to help. Their repeal is not a radical proposal, it is the restoration of the conditions under which insurance can function as the economically valuable institution it is designed to be. Full deregulation of health insurance would restore freedom of contract as the organizing principle of the insurance market. Insurers would be free to offer any contract that willing buyers wished to purchase, at any actuarially sound price, to any pool of individuals willing to aggregate their risks. The market would rapidly produce a diverse array of insurance products, varying in covered services, cost-sharing requirements, network structures, and premium levels, tailored to the diverse preferences and circumstances of different consumer groups. The Austrian insight about subjective value is particularly relevant to the insurance context. Individuals differ enormously in their preferences regarding premium cost, coverage breadth, provider access, and willingness to bear risk. A single politically mandated benefit package cannot reflect this diversity. It can only reflect the preferences of the political coalition that designed it, at the expense of everyone whose preferences diverge. A free insurance market produces the variety of products that matches the variety of preferences, allowing each individual to choose the arrangement that best reflects their own valuation, a fundamental requirement of consumer sovereignty. The treatment of high-risk individuals in a fully deregulated market requires a targeted, transparent policy response that does not destroy market function in the attempt to help them. Explicit, capped subsidies for high-risk individuals, funded through general taxation and delivered as premium supplements, can ensure access to actuarially priced coverage without imposing cross-subsidization mandates that distort the entire market. This approach is economically superior to community rating because it preserves market function while achieving the distributional objective, and it is more honest about the redistribution it involves because it makes the subsidy visible rather than hiding it in premium prices. Chapter 17. The Abolition of Public Subsidies and the Economics of Individual Responsibility. The most radical element of the libertarian reform agenda, the phased elimination of open-ended government healthcare subsidies, including ultimately Medicare and Medicaid, follows from a consistent application of the economic principles developed throughout this analysis. Open-ended subsidies distort prices, generate moral hazard on a massive scale, crowd out voluntary charity and mutual aid, and create the fiscal unsustainability that threatens the long-term viability of the entire welfare state. Their elimination is not a proposal to abandon the sick. It is a proposal to replace a system that fails them with one that does not. The Misesian critique of subsidies is precise. Subsidies falsify the relative prices on which rational economic calculation depends. When healthcare is subsidized, consumers demand more of it than they would at true cost, providers supply it at higher prices than competition would sustain, and resources are systematically drawn away from alternative uses that would provide greater value at the margin. The subsidy creates the appearance of affordable care while making care more expensive in aggregate. It transfers costs rather than reducing them. The moral hazard dimension of open-ended subsidies is equally important. When individuals expect government programs to cover their healthcare costs, the incentive to maintain healthy behaviors, save for future health needs, purchase adequate private insurance, and make cost-conscious healthcare decisions is systematically weakened. Subsidies for the ill and unhealthy, structured without regard to personal responsibility, reward the very behaviors that generate the costs being subsidized. A system designed on Austrian principles would make the connection between individual choices and their consequences clear and direct, creating the incentive structure that both promotes health and respects individual agency. The historical record of voluntary mutual aid societies, before their displacement by government programs, provides evidence that voluntary institutions can provide robust healthcare access to low-income individuals without the perverse incentive structures of government programs. Fraternal organizations, friendly societies, and cooperative mutual aid arrangements historically provided medical care, income support, and community solidarity for working-class populations at low cost and with strong accountability to their members. The crowding out of these institutions by government programs did not improve outcomes for the populations they served. It replaced accountable voluntary arrangements with bureaucratic ones and created the dependency relationships that characterize the current system. The transition from the current system to one organized around voluntary exchange and individual responsibility requires careful design of phase-out arrangements that protect those who have made life plans based on existing program structures. But the direction is clear: toward explicit, capped, time-limited aid for the genuinely indigent, toward market mechanisms for all others, and toward the voluntary institutions of civil society that a free people creates to care for those in genuine need. Part 6. Conclusions, The Path Forward. Chapter 18. A Unified Theory of Healthcare Reform. The unified diagnosis is Misesian. Each government intervention in healthcare falsifies the price signals required for rational economic calculation, generating misallocation that the next intervention purports to correct, spiraling toward total political control of the sector unless the logic is interrupted by a return to market principles. The employer tax exclusion corrupted insurance markets. Regulations designed to address those corruptions generated further distortions, The ACA universalized and entrenched the distorted system rather than addressing its causes. The exit from this spiral requires not better policy design within the interventionist framework but a fundamental reversal of the framework itself. The reform agenda ranges from the politically feasible to the philosophically radical, and both ends of this range flow from the same economic logic. Tax credit replacement, expanded HSAs, price transparency mandates, provider deregulation. These are achievable reforms that deliver substantial benefits within the existing institutional framework, each independently valuable and collectively transformative. Licensing elimination, pharmaceutical deregulation, full insurance market freedom, phased elimination of open-ended subsidies. These represent the logical terminus of consistent economic analysis, achievable over a longer horizon as their intellectual case builds and their political conditions develop. The key insight unifying both the moderate and radical elements of this agenda is that government intervention in healthcare does not merely fail to achieve its stated objectives, it actively prevents the market mechanisms that would achieve those objectives from functioning. Every licensing requirement that restricts entry is not merely failing to ensure quality, it is actively preventing the competitive supply response that would lower prices and expand access. Every insurance mandate that forces coverage of non-insurable risks is not merely failing to achieve universal coverage, it is actively destroying the actuarial soundness that would make voluntary coverage broadly affordable. Every price control is not merely failing to make coverage equitable, it is generating adverse selection dynamics that drive costs upward for everyone. Chapter 19. The Synthesis, Economic Analysis and the Free Society. Market-based reform of American healthcare is not merely more efficient than the alternatives, it is epistemologically necessary, Hayek morally consistent with human agency and self-ownership, Rothbard, and the only path to genuine and sustainable prosperity in this sector. Individuals treated as sovereign choosers, bearing the consequences of their decisions. Responsible for their own welfare, and free to arrange their affairs through voluntary exchange, generate the spontaneous order that central planners cannot replicate and do not understand. The Austrian tradition in economics adds the decisive epistemological argument. The knowledge required to allocate healthcare resources well as dispersed across millions of individual minds, is largely tacit and context-specific, and cannot be possessed by any central authority without systematic distortion. This is not a contingent limitation of current data systems or administrative capacity, it is a permanent, structural feature of complex social orders that no advance in artificial intelligence or data analytics can overcome. The price system is not one method among many for coordinating economic activity, it is the only mechanism that can utilize dispersed knowledge without centralizing it, and its suppression in healthcare is the fundamental cause of the sector's failure. The restoration of freedom in American healthcare is required for fiscal sustainability, as the alternative is the progressive escalation of government spending toward crisis. It is required for innovation, as the alternative is the suffocation of competitive dynamism that has produced American medicine's historic achievements. It is required for equity, as the alternative is a two-tier system in which regulatory insiders obtain high-quality care while everyone else navigates what the bureaucracy provides. And it is required for freedom itself, as the alternative is the progressive extension of state control over the most intimate decisions in human life, decisions that properly belong to the individual and cannot be made better by any authority external to the persons whose lives they concern. The conclusion of this analysis is unequivocal: the restoration of market mechanisms in American healthcare is not merely desirable but necessary. Necessary for fiscal sustainability, necessary for innovation, necessary for equity, and necessary for freedom. The tools for reform exist. The economic case is complete. The evidence is abundant. What is required is the political courage to follow the logic of economic analysis wherever it leads, and the intellectual honesty to acknowledge that this logic leads toward freedom, not toward a better managed version of the system that has failed. Government cannot save American healthcare. Only the market can. The sooner this is understood clearly, argued publicly, and translated into policy, the sooner the restoration of genuine healthcare, affordable, innovative, diverse, and free, can begin. Summary: diagnosis, economic logic, and reform. Agenda: government failure. Economic consequence: Austrian public choice. Nexus: liberty.